So to start off with, as you can see, the topic is going to be patient adherence, specifically with low back pain. So any results or studies will mainly be focused with the low back pain. So we can't necessarily say that the results are true, with shoulder pain or knee pain. So just wanted to emphasize that towards the beginning. Also, to start off with, what are some of the funny or interesting reasons why a patient might have reported to you, I couldn't do my exercises because of X, Y, Z. Let's hear some of them. I know you guys didn't have time is a pretty common one.
I wasn't feeling well.
Wasn't feeling well. Any other interesting ones besides the classics? Had to go to Vegas, couldn't complete it. Nothing I can do. What'd you say, Tony? Lost my paper, so kind of hard to do it. Too many to do. Yeah, we're gonna bring that up later today. Of maybe we might be giving too much on those handouts. Thought I saw another hand. Any other fun ones that? Yeah. Put your hand up, or you're just. Go ahead, Ken.
It made me hurt more.
Made me hurt more. So maybe of course they're gonna stop doing it because it hurts them more. So yeah, we went over this first bullet point. Why it might be difficult for certain patients. But what is difficult for you as a therapist to have a patient become adherent to the exercises? Because I know after their first, second, third visit, we say, how are the exercises? Go ahead and show me how you did them. I like to hear is something I've learned here from especially Tony, Y, and some of the other therapists of, hey, let's see how you're doing it. One, so we can find out, is there anything to fix? But two, it kind of gives us an indication of, if you were supposedly doing it, let's see how you were doing it. So what's difficult for you as a therapist to have a patient slowly become adherent or compliant with some of the home exercise programs? So only do the easy ones.
They have the limited time that we have with them.
Okay.
Yeah,
it's hard with 30-minute eval or 30-minute treatment. The first 10 minutes, and oh wow, we gotta do all the rest of our planned activities with them. There's a couple other voices I heard. So we'll just be thinking about those. If you had some come to your mind that you didn't want to share, that's going to be our topic today. Is hopefully that we can gain more adherence with our patients, with the program we give them, with the exercises they give them, and the study that there's going to be a lot of studies that I'm going to quote today, but the main one that I'm going to be going off of was efficacy of classification. Specific treatment, but mainly the second part of the study was adherence on outcomes in people with chronic low back pain. So they had two purposes with the study, but for purposes of today, we're just going to go over adherence and how that affected their outcomes, short-term and long-term, with the chronic low back pain. And those were some of the main contributors of this study listed below. Some of these were mentioned last time with Ken, I know, in his previous in-service in, was it July? So just as a reminder, so we can, see the importance of all this. So common is stat that, I've heard some people say here in the clinic, it affects 80% of the people at some point in their lifetime. And they even break it down more, saying 50% of them will have had an episode by the age of 30. So 50% of that was 80, which is a little surprising. I'm not even 30 yet, so makes you think a little bit about that. Fifth leading diagnosis identified for office visits from the primary care doctor. And the one that's interesting for me here is the recurrent rates within a year of having that, first low back pain is as high as 80%, 78%, listed in a couple of the studies there. So it's something that obviously you guys with months and years of experience have seen that, they come in, oh yeah, I was here 2 years ago, kind of back pain got better, but it's come back because of X, Y, or Z, whether it was a maybe a little event they had, or it just is simply coming back. So it's something that we still see is an issue within the medical and physical therapy world, where we're still kind of chasing relieving that chronic low back pain. Most frequent cause of activity limitation in people under 45, and third most frequent in people 45 to 65. So we can see that, the severity of this issue here. And it was interesting also to see that it's the most common type of chronic pain seen in a couple studies here with Pizzo and Clark. I don't really want to necessarily read over this entirety, but you can see the big one here: 50 billion each year, just in America alone, of how much insurance and money is outpouring into specifically low back pain. That's not even just pain; that's chronic low back pain. So we know, with a lot of the research coming out, some of the ones that Ken was mentioning last time, that we see that the doctors, they're being pretty particular in who they select for any surgeries, and we're going to talk about that in a little bit. But from the recent research, we know that exercise is, and that's just saying general exercise here, is one of the primary non-surgical approaches for managing the low back pain. But we can see underlined below on this next bullet point that while we know, there's evidence for exercise and moving is beneficial for treating low back pain, it's still limited on which one particular exercise is the cure-all, and that's not even something that we could claim right now. If you do stretch this, treadmill this, and we know there are results in the short term with relieving some of the pain, but there's still limited research on affecting the chronic low back pain months and years later of allowing that patient to get rid of it. So as we can see here, as I mentioned, 2% of people with chronic low back pain are treated surgically. So, all the referrals coming in, the doctors are relying, I don't know, is it fair to say more so these days on physical therapy of, hey, let's see if we can attack this with physical therapy to address the issue. And as we can see at the bottom, the success rate, this study was done in 99, so it's been 20 years. So I was hoping to find a more recent one. The success rate is no different from non-surgery rates long term. So the emphasis today on a lot of these studies is, while there might be short-term effects on certain treatments, the main goal here with the chronic low back pain is trying to address the long term, because we know 80% of them are going to have the back pain within a year again. So that's what we're trying to attack in this presentation today. And as you guys can see, all the different treatments people have said, I go to massage, I go chiropractor, I've tried dry needling, I've tried this exercise, and there's really a plethora of exercises that people have tried to come in, and you could see on their face, I feel like I've only been here a couple weeks, very limited experience with all this, but you could see sometimes in their face of hoping, I hope this is the last medical profession I have to go to, because I've been to this guy, I've been to this doctor, been to my massage therapist, and you could see it that they want it so bad to be relieved, but they still haven't been able to take care of it fully. And again, we can see no consistent effects of any one particular type of treatment long term. As we said, there was many studies Ken mentioned earlier that were great, that showed the results, and the emphasis here is that we're trying to find is some of those long-term outcomes. So yeah, as I said earlier, that we're trying to look at the adherence specifically and how that's affecting the outcomes in chronic low back pain. They did have a different part of the study, but I didn't want to include that. So basic inclusion, 18 to 60 years old, they had to have had the back pain for at least 12 months. And you can see in the exclusion, anyone who had an acute flare-up around the time of the study, they didn't include, and no history. This kind of takes out a lot of possible patients of ours of spinal deformity, disc herniation, pain, or paresthesia below the knee. So just to keep in mind of who we can actually relate the results of this study to, because these are the people they included and excluded from this study. They measured them at baseline, after the few months of the treatment, and then 6 months later and 12 months later. And I tried to put in bold here. It doesn't look actually that bold even on my computer. The main outcome they were looking at was the modified Oswestry, and they additionally looked at pain rating scale, medication use, how much time they had off work, because we know that's a big reporting limiting factor of patients coming in, hey, I really want to go back to work. It's hard to just take off even a week at a time. I think Mike, we had one last week. She was wanting to go back to work, even though her doctor said, hey, we really don't want you going back to work, but we know it's something that is affecting them in that base, and some of the other outcomes they used in this one. So in the study, everyone who participated in the study received performance training, which is anything like, hey, you're sitting like this, let's try to sit like this, how they're standing, how they're walking, how they might be bending over to pick up something from the floor, how they're sitting up, movement in general, not a specific exercise. And they also, everyone in the study received exercise training, whether it be a stretch, any strengthening workouts, core exercises. And afterwards, if you're interested in the specific ones they used, I could show you the title and where to find the article. But just to emphasize, they both received, there wasn't a performance training group and a exercise training group. They all received both types of exercises. And they to do the self-report, they did, okay, take a journal each day and write down which exercises on both sides, performance and the exercise, if you did them or not, and then the therapist would follow up the next visit. Hey, which ones did you do? Just to see on the bottom if there's consistency between the two reports there of what the patient was writing down in their journal, and then also what they're reporting to the PT. And they did see that there was consistency between what they were reporting at home and what they were giving back to the patient. And so these two graphs is really the big take-home points of the study. We can see in the left side, the exercise adherence, both of them started out at about 80%, towards the beginning of their treatments. And it's dropping down, heading towards about 39%, we'll see later. And the performance training group, their adherence, not group, but the people, how much they reported doing their performance training, didn't decline as much as the exercise adherence activities. So this is actually, 80% down to 40%. It's actually quite more of adherence than other studies. This one wasn't part of this study. It was by, I don't even know how to say his name, Beinart, and another one by Friedrich that were reporting 50 to 70% of the patients with chronic low back pain actually aren't even doing any of the exercises. So this study was actually a little bit more, but it's consistently showing that at least 50% of the exercises that the physical therapists are giving, the patient simply doesn't do for all the reasons we listed at the beginning and more. And the bottom part of this is just trying to emphasize that it does matter, the adherence to our exercises, because it shows in the white color, those are people who were high compliance. Down here it's showing which meant at least 60%. And then the low compliance was anyone who's doing less than 60%. And we can see from the initial point down to discharge was quite a big drop compared to this group here, which is the low compliance, less than the 60% of doing their exercises. So it's not anything quite different from what other studies are showing with adherence to exercise. But what was the difference was the performance training group was at least 60% adherent or more. And we could see for quite a long time it stayed at that 80%. That's 150 days out, still quite high until later on in the year. It might drop a little bit, but it's at least staying above the 60% whereas the other group's going down towards 39. So the result specifically was, as I mentioned, the performance training adherence declined significantly less than the exercise adherence activities, and the exercise adherence began to decline, as we saw, immediately in that graph, versus the other one was able to stay a little more in that plateau. And we could also see that the group that adhered more to the performance training had a unique independent effect that was significantly better than the exercise adherence group. And the exercise adherence activities, they didn't have any significant difference with their modified Oswestry scores. But what they did find that was interesting is they compared using all the stats that I don't want to get into today. Of there was actually an even greater improvement in the modified Oswestry for those that were doing exercise and the performance. So it's not to stress that, oh, don't do any exercises. It's saying the majority of their improvement was coming from the performance training, but there was even greater improvement in their modified Oswestry if they were also doing the exercises. So both are important, but this study was trying to say a majority of that, as seen down here, a majority of the improvement was because of the performance training. And just, saying the same thing over again, the more they were adherent, the more they were able to improve on their modified Oswestry, and vice versa. The less adherent, the less their outcome was. So to conclude with this study, though, just to hit it again, this point, it was uniquely related to the performance training and not the exercise training activities. And the result, sorry?
Performance training meaning functional training?
Yeah, so they say performance training, which was functional training. So bending over, posture, how to do things, performance/functional. That's just the name they gave in there. But yeah, thanks for clarifying that. And again, the importance of this was that the outcomes lasted long term. It wasn't just short term. Their modified Oswestry was improved. It was long term that they were having decreased back pain. So here are some just kind of classic ones that patients say, okay, when does it hurt your back pain? Getting in and out of the car, standing up, when I do dishes. I can't pick up anything on the floor unless, there's a furniture table. What are some other ones that you guys have heard, I guess, that aren't on this? This is a very small list. Our patients are coming from all types of careers, jobs, being at home. Is there any other ones that people report, oh, it's difficult to do this? Going up the stairs, yeah. That's a common one. Just getting up in the morning in general, out of bed, yeah. Getting out of the car. Being intimate, yeah. Maybe it's something that's they're afraid to say the first visit, but I'm sure there's more percentage of people with that are afraid to say it. Yeah.
Just going back up, in the conclusion part, I was hoping to find the reason why the performance group or the functional group was able to stay a longer period or get better results. Is it because they had more meaning in doing the functional activities or the performance activities versus the specific exercise?
I wish I would have delved a little more into the study of the specific reason why. It could be, this is just me, hypothesizing here. It could be because, it's easier to remember what you say. I know I've been trying to do this. Tony and Mike at my CIs have been helping me lately of, hey, good exercise, but how can we make it more functional for, you're strengthening their hip flexor, but they say it's hard to walk. So let's, walk over a hurdle. Let's do some of that. And, or even posture-wise, the patients have been reporting, I keep remembering in your voice, like, okay, you gotta look back, and because we're emphasizing, hey, this is the posture that we're seeing, and throughout the visit, reminding them, hey, remember, don't bend over like that. But yeah, I wish I could have answered that with more of a reason. Yeah.
I guess sometimes when just the one that I've observed is that when they're why they're doing something like that, and what it'll help them improve
Mm-hmm.
in life later on, or what they're doing in their current activities.
Mm-hmm.
The performance ones or the functional ones, those have a link to what they're having a hard time doing at home, and they can see a relationship to where that might help them.
Exactly, yeah, where maybe sometimes the exercises we give are perfect for strengthening or improving whatever, but maybe we don't spend enough time of, hey, this is why we're doing the bridges, or this is why we're stretching this. So maybe, like you're saying, at home they don't like, oh, why am I doing this? But with the functional, at least they know, okay, I can see when I move this way, it hurts less.
And that's just what I found. I was just wondering what they found.
Yeah. Yeah, I wish I could have had a better answer for that on that one. I wanted to for a little bit. One thing that's been great working here is, I mean, I haven't been around a lot of clinics getting hours for PT school, but I feel like here it's been awesome to see so many PTs and PTAs where it's, hey, you know, I had a question about this. What have you seen that's worked? And there's a true camaraderie here with everyone. So I kind of wanted to use that to my advantage here in this little in-service, just because you guys feed off each other so well. Of, hey, I tried this. What have you seen to be helpful? And I think that's great. I hope to find a job at a place like this where it's everyone's working together. So I wanted to get, I don't know how many there are, 1, 2, 3, 4, 5. There's roughly 15, 20 of us. So maybe we're going to get into 5 groups. 4-ish people. I don't know how we want to divide this. Birthday, Star Wars, Harry Potter, I don't know, Marvel. So, or just people near you. So let's get into 5 groups of 4-ish people. Let's try that first, and then I'll assign. What we're going to do is for 5 or 10 minutes, within those 4 people, I'm going to assign which group functional training you're going to talk about. And I hope between you 4 or 5, you can say, okay, if someone's like this, this is how I have seen work out to my benefit for the patient to improve. Just so we could, feed off each other's ideas, because I've seen so many here of, oh wow, I wish I would say it like that for the patient to improve. And then we're going to get together at the end and just name some of the big points within each group of how to address some of these common pain situations. So go ahead and get into groups, and then I'll assign which number.
Dennis, what are you going to report for us?
Yeah, here's our bearded speaker talking about sitting positions for low back pain.
Share with the rest of you.
Yes, and this is our man that did have the low back pain.
What's our...
All right, D-Dub, when your back was bugging you, how'd you have to
my
sit?
back was bothering me.
Sitting.
It hurt actually to sit properly, like 90 and all that. I actually legit had to low rider all the way back. So a car would pull up next to me and I would be like this, looking like a fool. but that actually is what.
But it felt better.
Which is kind of the opposite of what we've learned.
Okay.
Suggestions, we should just follow this.
Symptoms. Like,
Yes.
Yeah, exactly.
Symptom modification, I guess. So I think that's where I hear a lot of the therapists start saying about, how do you flip? Bam! All right, we got a powwow here. A lot of the therapists that I end up hearing saying is that stuff that we've been taught at school. You gotta have perfect posture. We've got all kinds of graphs and charts that show us that where perfect posture is. We got these charts that show us where the monitors are at and everything, and where they're supposed to be, and we don't deviate much from it. So most recently, just like Dennis was saying, that he felt good in here, and I ask him sometimes, what makes you feel better? Does it give you relief if you just slump down for a moment? And then there was a study that showed that the people with chronic back pain actually have some of the best postures. And when they had surgeons and physicians look at a picture of what somebody looks like, they had to choose who's got back pain, who doesn't have back pain. And they couldn't determine. In fact, the people who had back pain had the best postures compared to the other ones when they saw that. And we're guessing it because the people who didn't have any back pain can just sit any way they want to, and they're just relaxed in it. And they weren't suffering from having to fix their positions as much. But now I started telling them, hey, what feels feels comfortable for you. And if Dennis says that, oh, this felt pretty good, I'm going to stick with that. This is what I tell some of the patients too.
Yeah, it was totally mechanical. Immediately, if I tried to like sit up at all, it was just like sharp.
Okay.
Opposite of what you guys.
And then there's some people who do follow it, who feel really good like this. Yes. What do we learn in school?
Maybe 2 or 3, 2 more minutes, and then kind of think of which comments you want to bring back to the group.
We're going to send all of them. All of them.
But I think that's a good point, because I think what I tell my patients too is like, you don't have to hold this 100% of the time. The point is, you know where the right position is, and we're going to deviate from there because of either symptoms or sometimes just because we have to move it. It's just to have that flexibility, but to know at least where to come back to, and then be able to move in and out of that position.
And that's why I like the push for movement, because if you have to, we're designed to move. And maybe the pain is telling us that, oh man, you've been here too long, it's time to move. Oh, you've been here too long now, okay, it's time to move. Because our circulatory system and our discs, that's how they get nutrients, that's how they get blood flow and nutrient exchange. But I like the new movement push.
Big cues or items you could put with the patient that you guys discussed that's been helpful for you guys as therapists. Just a couple you want to share with the...
So I think we started off with just understanding what normal, optimal posture is, but there are times when you're going to get out of that. So Dennis reported, like, when he had his back injury, that optimal position made him worse. So based on symptoms, they can deviate from those optimal positions to accommodate their symptoms. And so educating them on that, I think, case specific, so it would be like, what does your car seat look like? What does your desk look like? And then, educating them on based on what their environment is, because we all don't sit in the same environment, even if we say it's a desk. Your home desk, if you're working from your house, is different than what you would have at the office. So we made modifications based on what people could do and what they could handle, and then based on their symptomology.
Cool, thank you. Any other thoughts you guys have?
We've not really come up with any standardized thing for what is supposed to be the perfect posture when sitting in a chair. And I think the movement thing was the biggest thing we were looking for, is that we're designed to move, and our pain when we feel uncomfortable is designed to tell us that, hey, it's time to get in a different posture. Oh, wait a minute, it's time to move again, just so we can get increased circulatory flow in our body. And it doesn't follow some of the stuff that we've learned in school, where the computer monitor is right here, the keyboard is right here, our chin is right here, and we have to set up our car seats in a certain way. Just because Dennis was mentioning that he felt better in a lowrider driving position like this when his back was bugging him. And
I think those are good points, because I think we need to ask questions of these chairs in the clinic. We set them up in, how does that feel good? But how is it at home? What's your exact environment at home? And try to case by case, as you said, match them. Okay, thank you guys. That was good. The next group, the walking is causing pain for the 10 to 15 minutes. How can we get people to, hopefully bump it up to 20, 30 minutes?
So we think if it's more like an endurance issue, then we need to modify with, walk less minute to start, and with frequent rest to build up the endurance. And if someone is having more of a structural issue, like less stiffness happening, so we can build up, try to work on some different type of manual treatment to help increase the movement, so they can walk more than 10-15 minutes. Or if someone is more like a performance issue, more like they don't have enough trunk muscles or leg muscles to help them to control their to stabilize their back. So then we'll be more working on more like a stabilization exercise that'll help them to be able to walk longer. That's what we're thinking.
Yeah, awesome.
Yeah, so it just depends on what type of patient we're dealing with.
Which is good. I like all these end comments. Depends on the patient, because it's not a standardized fix all be all, which is kind of the whole point here. Is let's see how they are in their environment and try to address that functional part of it. Cool. Any other ones on that, or?
Kyle has
more, but I guess whoever wants to share. But it was actually a pretty good.
What you were saying earlier. Okay, so we're going to go to group 3. It's hard to stand up, sit down, or bend over to the floor. What are some of the good ones that you guys thought of?
Go ahead, Lars. Take over.
Kelly.
No, go ahead, Lars. It's all you.
Mike and
Well, from the floor, it was a suggestion that I guess passed. So if you don't have any furniture, you go down on one leg, pick up, and then you push it. And depending on where you feel stronger, you switch legs.
good, yeah. Sometimes it might be too difficult to just squat all the way down and maybe go into the knee. We can try, and if it works for that patient, good.
Movement modifications.
Any other modifications or thoughts on this one? If not, I think that was a good one.
That was a winner.
That was the winner.
Yeah. Okay. Thank you. Yeah. How about group 4? Bed positioning, lying on the side, toss and turn all night, and every time I turn it hurts, or whatever ones you guys thought were key.
We would educate patient on log roll and also favorite position and assess and see, also make sure that their spine is in a good alignment and neutral, and then just add pillows if they're on their side between their legs, or maybe if rolling a towel underneath their trunk just to make sure that their spine is in a good alignment.
Good. Yeah, I think some patients are like, I don't know, it hurts at night, and then they show us, and it's I do that and then that. Awesome. Any other thoughts? Or that was the main one you guys felt was perfect. All right, final group in the back. Can't tie my shoes. Need my spouse or friend or whoever to do it. How can we help them?
We felt that we probably want to begin globally to take a look at a postural analysis as well as a movement analysis. If there were any notable impairments that we could distinctly address in that sense, I think we would start there. And once again, it depends on the patient's preference. So how they go about it, if there are any aberrant movements, any precautions that might be leading to that pain, we would address it in that fashion. I think coming up with options, I thought Tom came up with a couple different variations, and we all kind of piggybacked upon that. We would just want to optimize what they felt comfortable doing, and obviously doing it in a pain-free manner. So we would just.
Is there any movement specific you guys?
Tom, did you want to demonstrate the 2 renditions?
Sure.
Depending if it's flexion or extension bias.
Looking at hip flexibility, you would do something like this like Ken demonstrates, and across the leg from here as opposed to going down to the floor where your shoe is. If they don't want to sit down and do that, they can always do a Captain Morgan, where they bring the foot up just like this, working on the hip hinge.
There we go.
And flexibility. If those aren't comfortable, there always are things like the hip kits you can use for adaptive equipment when you're using the pant leg pull up just like this. Different things you can kind of try out.
I like those. Yeah, I've never seen any of those before, so it's good to see those. Cool. Any other thoughts on any of these before we finish up? I'm going to show a couple more things here real fast. I think the big takeaway of that study, obviously your years of experience are going to help guide you for addressing patient by patient case, but I think the emphasis here was exercises are important, additional to the functional training, but let's just make sure we're putting enough of our treatment time of, hey, it's still hurting you with this, maybe let's watch you do it, see if we can adjust it, just so then they're more thinking about it at home versus understanding, okay, I have these exercises I need to do to get my back pain. But you guys obviously have the experience to guide you, but at least I'm going to try to put a little more emphasis on the functional training. And one last, I was reading the systematic review of improving adherence to home-based exercise. So this was kind of covering all points of how social support affects your low back pain, how guidance from the PT. So this was saying in subjects with musculoskeletal pain, back pain, lack of positive feedback from the therapist predicted non-adherence. So as we're going over the exercises, the next visit, we're always saying, good job on this. Let's try to move it this way. At least giving the positive feedback towards them shows that there is an increase in adherence. this one I thought was interesting, as Mike and several others of you mentioned. The number of exercises, sorry if you guys, oh, I'm not even on the right screen. There we go. Okay, now I got it. Okay. So the interesting one here was the number of exercises prescribed at home. They found that if you did more than 4 exercises, they were less likely to be adherent to those exercises. They found around 3 or 4 was about the kind of the prime number, even possibly fewer, maybe just a good take home, hey, this is really what we need to attack in how you're moving or not moving. Obviously there's patients who, hey, give me everything, and if there are those patients and are doing it, then why not? For, this other systematic review talked about self-motivation, if previous adherence behavior, low level of physical activity, they'll show to be less adherent. Obviously, if their pain's increasing during the exercise, they're less adherent. So we need to see, okay, show us how you're doing your exercise. Ow, it hurts. Okay, let's see if we can address the pain during the exercise we gave them. Otherwise, they're not going to do it at home. And then, as we've might have seen here in the clinic, high degree of depression or anxiety will be less adherent to those exercises. So I have the name, if you're curious, of this systematic review that showed other important aspects to adherence apart from the functional training that we need to be aware of. That's all I have today. If you guys have any questions, I didn't want to go the full hour just because we know you guys have patience in 10 or 15 minutes, but I love the thoughts. There's a few take homes from each group that I got, me personally, so hopefully the rest of you could look at some of those examples. Done with everything I had to present today. Thanks for being permanent. Thank you. Still more cookies by the one and only Michael Salazar.